Welcome everyone. I'm Mona Kalra. I'm the Education Coordinator of the Neuroscience Division. We would like to welcome you to this special webinar, a pragmatic overview of the research and implementation of telerehabilitation with neurological population. This webinar will provide an overview of the evidence for telerehab. It will cover special considerations in using telerehab with individuals living with neurological conditions. Our speakers will provide clinical examples and lessons learned from their own research to help you best implement telerehab into practice. This webinar was put together in a short period of time to respond to the COVID-19 situation. Our presenters today are Dr. Dalia Carey, Dr. Ellen Corriveau, Dr. Sarah Donkers. This webinar will be recorded and posted on the Neuroscience Division website. If you have any questions to be addressed in future webinars, please send us an email. There is now a section on Neuroscience Division's website dedicated to COVID-19 and neurological physiotherapy. I'll now ask Dr. Sarah Donkers to continue.
Thank you, Mona. And thank you everybody for joining us today. I hope everyone's keeping well. Because we're talking about telerehabilitation, there's a few essentials regardless of the population you're looking at that need to be addressed. So we are a provincially self-regulated profession, which means before you use telerehab, you need to check with your local provincial policies and practice guidelines. In addition to the informed consent we use for any intervention with our clients, there is consent specific to using telerehabilitation. And also, most of you will have chosen your platforms by now, but we recommend that you look at all the platforms out there and that you're confident in your platform selection. You need to make sure that it is secure, which means that it is an encrypted end-to-end platform. So FaceTime and Skype don't meet that marker. Insurance is another thing to consider. So if you are in private practice or you run your own clinic, you might need additional insurance to cover delivering telerehabilitation interventions. And then the other component of insurance is to consider what companies you can claim telerehab interventions through. So Sun Life, for example, I know does a full reimbursement similar to as if you're doing an in-person session with your clients so that your clients can then claim for their coverage. Lastly, cost. We get a lot of questions about cost. Our standpoint is that the research shows you are delivering as an effective, if not more effective, intervention with telerehabilitation. It is a quality intervention, and therefore you should be charging to represent that. And we recommend charging for the same cost for the same amount of in-person time. That is your own personal decision though, but do remember that our scope of practice goes beyond just manual therapy, and we can offer the education, the prevention, the support, the movement analysis that is part of what our effective interventions are. Okay, so the other thing I want to share is some of the key resources. There are so many that have been put together lately, so hopefully you guys are able to access some of those. But specific to using telerehab in physiotherapy, be sure to check out the CPA position statement. Also, our Canadian Alliance has information about delivering telerehab and delivering group telerehab interventions. As I mentioned previously, we are provincially regulated, so you have to look at your provincial bodies. And I encourage you to look at both the association webpage as well as the college websites, because you might get some useful tips from the association or some local resources, or maybe even access to like a knowledge champion, whereas the college website is going to provide you more of your regulation and bylaws that you have to be considering. And then lastly, be aware of client resources. So for example, the Canadian Stroke Foundation right now, so the Canadian Heart and Stroke Foundation are offering every Wednesday and Friday afternoon free online classes for individuals post-stroke. So I've put the website in there. We will post these slides afterwards, but I'll just pause here for a second if anyone needs to take a screenshot. These classes have a topic of discussion, it provides an opportunity for support, and then it offers, I think, a 45-minute exercise session followed by some cognitive games. So I think that's really great. I encourage you guys, we do have Janelle from our neuroscience division monitoring our chat box today. So I really encourage you guys to share any resources that you have found useful in the chat box, and we'll collate that. Okay, so because of this COVID-19, telerehabilitation is new to a lot of people, or they're rapidly putting it into place. Although the research on it has been going back 10 to 15 years, the actual implementation is rapidly developing because of our neuroscience, or our COVID situation. So on that note, Jennifer O'Neill is doing her PhD in Ottawa, and she is looking at using telerehabilitation in moderate to severe TBI, but she's specifically doing a study on barriers and facilitators from physiotherapist perspectives on implementing telerehabilitation. So she did say if you have some questions about telerehab or on TBI, you can contact her. So her contact's at the top here. But because many of us are implementing it into our clinical practice, or being forced to implement it into our clinical practice, I think this is a really important time to gather some of the data that she's looking at. So if you have the time, please contact her. You have to be a physiotherapist. You don't necessarily have to be working with telerehab at the moment, but she is looking for physios who work with individuals with balance and mobility. Okay. So please share your resources, and just to give you a little overview of what's going to happen, I'm going to pass it over to our Quebec team, who's really the experts here in telerehab and neuro populations, and they're going to give us some information, and then I will wrap up on some MS specific stuff.
Thank you. Thank you very much for introducing us and organizing this webinar. So thank you very much for organizing this and for everyone attending. Absolutely, Sarah, you're right. This is very timely with the whole COVID situation. And we know that there are a lot of physiotherapists interested in considering telerehabilitation, but they also have a lot of questions. So we hope that this will address some of those. So my name is Dalia Carey. I'm a professor at Université de Montréal in the physiotherapy program, School of Rehabilitation. And I'm a researcher at the Center for Interdisciplinary Research in Rehabilitation in Montreal. My areas of interest in research are regarding the development, evaluation, and implementation of innovative technologies in rehabilitation, including telerehabilitation. Therefore, that's why I'm here today, presenting you a little bit of findings and experience from our research. I'm going to pass it over to Dr. Hélène Corriveau, my colleague, for her to present herself.
So, welcome. I'm very pleased to be here today to present our works, and I hope can help a little bit to you how to use telerehabilitation. I'm a full professor in the School of Rehabilitation within the Faculty of Medicine and Health Science at the Université de Sherbrooke. But I'm also a senior researcher at the Research Center on Aging at the Sherbrooke Geriatric University Institute. My primary research themes are prevention of fall, balance problem among healthy elderly persons, and among those presently motor impairments as stroke, and also evaluation of the implementation of various program integrated intervention such as telerehabilitation. But I'm also part of a research team specializing in home telerehabilitation, working since 2003, named ESTRAD, that you can see, led by Professor Michel Tousignan. That's you.
Perfect. Thank you very much, Hélène. So what we're going to be addressing for the next little while, we want to first go over and make sure we're all on the same wavelength of what we consider to be telerehabilitation, and then give you some examples of different target populations that it's been used in our research. I'll then be talking about what the literature tells us on the effects of telerehabilitation, which speaks to what Sarah was mentioning before about the costs or what we can charge, or the fact that we're offering quality interventions. We'll then discuss some of the common technological constraints that arise, because we know that that's a reality when we come to using technology on the field, and finally end off with some specific telerehabilitation considerations when you put it into practice.
So let's begin by why you consider telerehabilitation. Now with the pandemics, our patients are at home, and we are at the home or institution. But you want to increase accessibility too fast. You want to increase accessibility. How you can treat the patient while maintaining quality of treatment and patient safety. Oops. Okay, how you can do that? So you have to change the clinical paradigm. Our target is telerehabilitation. Telehealth include 4 categories: teletraining, teletreatment, telemonitoring, and teleconsultation. We target on telerehabilitation, so it is teleconsultation and teletreatment. Teleconsultation, perfect. So the target population we work in our team is post-stroke with balance problems, post-stroke with anemia, post-stroke with upper limb problem, Parkinson's, but we also work with other specific problems that you can see. But what is important for all patient population is the first session. We have to prepare the first session. So when it's a first session, we have to take your time, adjust your position, and give verbal instruction that the patient and the caregiver can understand. You must very often ask, do you understand what I need? Because perhaps like now it would be perfect for the sound, but you must be sure the patient and the caregiver understand. For the physiotherapist, start with that you know. It's not the time to try a new therapy. Start with what you know, what you're comfortable with. Be very familiar with the pathology. By example, Parkinson's is a slowness disease. So what you have to do is give explanation. Explanation is important. We have to work on each step. And after that, work on the whole task. For this population, you have to allow time for the body to respond. And the patient can feel it. So after that, you can correct. You cannot give too much cue for this kind of population. For balance and gait problems in stroke, safety. All the time, all the clinicians ask me, do the patient fall? No. Since 2003, the patient didn't fall. But we take care. At the first session, we discuss with the patient and their caregiver to find a solution where they feel safe. Sometimes they find the solution. The walking belt is not always the solution, especially when the caregiver is short. Thus, and this time, the patient will have to hold on to a sturdy chair. Several techniques can be adapted. Be creative, you can do it. Now, after the first session, during the intervention, access fatigue and exercise intensity using the board rating of perceived exertion scale on 10 or on 20, it depends what you're using. Why? It's because in physiotherapy, you know that intensity is very important. So even the patient at home, you must take care of fatigue and exercise intensity. Another thing is very important. Don't forget to give exercises for between sessions. The patient must work between your sessions. If you want to keep, again, it's the same thing. It's because we want intensity. Now I will present you a video. It's a stroke just 2 weeks ago. He has a stroke, and we begin therapy 2 weeks after stroke. Yes, just 2 weeks later. It is a Tai Chi intervention video that you will see. Not the patient, how he works, but not the caregivers too. Also, I want you to see above on the screen what the patient sees, but in full size in its screen. So it's the first seance, first session. You can see the caregiver is very short, and she holds the patient and doing the same thing at the same time. How you can see also is the patient follow the therapist in the corner, but the patient see everything. See how the synchronization is good. How you can look at the weight transfer. Now it's after 8 weeks of 8 weeks of intervention. Look at the patient. Look at also the caregiver, how she enjoy it. It's a problem for us because she's not watching too much, but we have a chair for the safety. She's watching. Look at the caregiver. She's watching the patient. Good. So, how do you know how the patient can follow the physiotherapy orders? We can see that we can give treatment even with a patient who has balance problem. And it's very interesting to see how the patient and the caregiver was in relationship with the therapist. It was really possible. Now, Dalia?
Thank you, Hélène. So I'm going to take the next few minutes to give you an overview of what the research tells us about telerehabilitation, the literature. So you've had some examples of what we've done in our research. I'll give you a bit more of an overview of what we know in the literature. As was mentioned earlier, the literature goes back quite a few years, over 10 years. So there's a big body of literature. There's different types of studies. There are feasibility and usability studies. There are quasi-experimental studies, so studies that look at pre and post-intervention. But we also have a lot of randomized clinical trials and non-inferiority trials, so trials where we're comparing it to another intervention and trying to show that it's equivalent. We have studies that summarize some of these clinical trials. So for example, in this publication, Colin 2019, we have 6 clinical trials that took place across Canada, and some overarching findings are presented in there regarding stroke telerehabilitation. We also have a number of systematic reviews, and if you're going to start up in telerehabilitation, I'd encourage you to go to some of these systematic reviews, and you can see here that they go back a number of years, but interestingly, they actually have very similar findings throughout the year. So it's been pretty consistent. And in the studies, the telerehabilitation is either provided with a patient at home, or sometimes in a group intervention. So they could be in a community setting in a group, or they could be at home, each individually, which may be more relevant in the current COVID context, but with a group intervention, so led by one physiotherapist, or it can be interventions that take place between institutions. The types of clientele that are reported in these studies are the following. We have quite a few in neurological rehabilitation, so chronic post-stroke patient populations, MS, adults with mobility problems, elderly population after a fall or with a fear of falling, spinal cord injury, acquired brain injury, and other patient populations, elderly post-hospitalizations, elderly patients with knee pain, also cognitive behavioral training, which can apply to different patient population, and for cardiac rehabilitation. What does the literature tell us in terms of effectiveness and efficacy? So at the clinical level, the literature is pretty consistent in telling us that telerehabilitation is at least comparable to that can be achieved in person or with a face-to-face intervention. So some of the studies are looking at whether it's better, but that's not consistently found in the literature. And the objective is often not to be better than what's currently done, but to provide an alternative for when in-person treatment is not available, as is the case at the current time. And these studies have found that there's an impact on a number of outcome measures. So ADLs, return to work, range of motion, walking, balance, pain, cognitive tasks, skin integrity, fatigue, confidence regarding falls, quality of life, anxiety, and depression. So we can see not all the studies look at everything, but when you summarize the literature, we can see that we can have an impact using telerehabilitation at a number of levels. And many of these studies are good quality studies. Some of the studies also look at measures that are more regarding process measures. So for example, they find that there is good attendance rates to interventions that are done in telerehabilitation, and good compliance with recommendations or exercise programs that we provide them. The studies often report very few adverse events, sort of what my colleague Hélène mentioned before in terms of falls. If well prepared and well planned, very few adverse events. And when they look at the duration of the consultations, and I know that some clinicians wonder about that, are they going to be able to do it in the same amount of time that they do it in person? They found that the durations of the consultations can be similar or sometimes even shorter. There is a high satisfaction rate, especially among patients who appreciate very much being able to have access to these services. And I indicate here satisfaction rates higher for patients than clinicians. Clinicians will tend to be more frustrated by technical problems that there may be, and that's going to come up a little bit later on. They do, however, find that sometimes some of the assessments or some of the treatment plans may be incomplete when everything is done by telerehabilitation and there's no in-person component to the care plan. And that's something to consider. And in some cases that can be remediated and you can combine the two, but in certain circumstances you can't. And you need to be aware of what you might be missing when you're not doing it in person. In terms of these types of measures, there are fewer studies, though, that look at these types of outcome measures compared to the clinical efficacy. And with regards to costs, which often come up, there are few studies examining this aspect. One of the problems with the studies that do look at this is that the costs will vary greatly as to what's included in the studies. Are the technologies included? We're talking about costs for who? Are we talking about costs for the person, for the patient, for the caregiver? Are we talking about costs for the healthcare system as a whole or for the healthcare institution? It's going to depend also on the distances that are normally traveled and might be avoided with the telerehabilitation. And of course, the greater the distance, the greater the savings might be. But overall, in the studies that do look at cost, tends to be, there's a trend for lower costs for the organization that's offering the telerehabilitation. But we would need some more detailed studies, and perhaps with increased use of telerehabilitation at the moment, we'll be able to do that. A few other findings that the literature tells us, and that may be of a concern to the therapist, is that a good therapeutic relationship can be forged using telerehabilitation. You can have informal conversations with the patient or the caregiver the same way you would have in person. You can talk about the weekend, about their grandchildren, etc. What we do find, though, repeatedly is that telerehabilitation integrates more easily into existing activities and services. And the research shows us that. And my colleague Hélène mentioned that before. Start with something you know already. And also in terms of if you're in an institution and you're working on developing new programs, integrating telerehabilitation at the start of the program may be challenging. And lastly, as I mentioned before, technical problems do have a major impact on clinician satisfaction. So it's important to really consider how you want to organize yourself, how you want to set it up, and start slowly and building that confidence.
Just speak about just a little bit about technology. What we need: equipment, software, internet. Many technology options are present. On what you pay attention to is security, confidentiality. It's very important. Durability. Help and support. Do you have technical support if something arrives? But also, do you have clinical support? Do you have a champion like you must have in Ottawa with Jennifer? Do you have technical and clinical support who can give you help if you need to understand how to evaluate the balance in the store, how to evaluate the speed of walking? So you need a clinical champion. The cost often is important. It depends. It must be easy to use. Like Dalia said, the clinicians are not satisfied often with the technology, but perhaps it's not easy to use. It must be easy to use. So it's functionality versus needs. Next. But in the field, the variable internet conditions is very important, because sometimes you have picture degradation, delay, and desynchronization. I will explain a little bit more after. But we also have cancellation, and it's not fun, cancellation. It's not fun for the patient and either for the clinician. Sometimes it's a technical issue, yes, that you can fix it. But sometimes it's the participant forgets, and they just not forget. They think that because they will have the therapy at home, the patients think it's easy to give another time in the day for treatment. They don't think that you have a lot of patients that you will have to treat in telerehabilitation. So you have to explain to the patient that it's very important that they have to be there at time. So what's poor internet condition? The big problem for the internet condition is the bandwidth. You will understand what I mean. If you are working with people who they are at home, and at home we have the children are on Netflix, the husband is on Teams because he's working at home, probably you will have internet problem. You will not have a good bandwidth. I learned this word since I worked in telerehabilitation. It's very important because we will have poor degradation. Poor degradation is like we can have a good image, picture. You can also have, next one, delay. So delay is not good too because you speak and the patient move a little bit, not very long, just 1 second perhaps, but it's too much for the therapist. And the last one is the desynchronization picture sound. So you speak, but how you speak, the image is just after. So that's not very good for communication. So the three problem is due to poor internet condition. And so sometimes you just have to say, it's possible for the hour treatment that you will have just and me on the internet, just me, you, nobody in the house are using internet. So sometimes it's just that you have to do. Next one. So, Dalia, you can keep.
Thank you, Elaine. So I'm going to talk a little bit about a few tips that we've learned from the literature and from our research experience for the successful implementation of telerehabilitation. And these are points that are specific to the fact that we're using a technology where we're not seeing the person in person. So obviously, it does not allow for hands-on assessment or teaching. So we need to think about how we can either do something, have an alternative, or do that at a later time. We have to also remember that we can only see what the camera sees, and the patient can only see what the camera sees. What I mean by that is that if you have someone helping you for technical support in the room, but they can't be seen, the patient needs to know that there is someone in the room. Or if you want, if you want to assess they're walking, for example, and they're going to go out of the camera view, you may need to consider having different types of cameras set up in the patient's home. So what we call a pan, tilt, zoom camera that can move with the patient. You have to consider speaking etiquette. You have to wait your turn to speak. You have to know that there's a delay and wait for the response. If you're going to use the technology to show anything, for example, an exercise, a document with an exercise program, make sure that what you're showing them are simple, clear documents, and you want to maybe use your mouse as a pointer, your computer mouse, because they will see what you are seeing on the computer. And depending on the technology, you may not always be able to transmit both the video and a document, for example. So I'm doing it in this case, showing you my PowerPoint and my camera, but some of the technologies will not allow that. Or you will not be able to see the patient when you present something. A few other things to consider, specifically when you're doing physiotherapy assessments and interventions, is to really plan, come well prepared, have what you need with you so that you don't have to get up during the sessions to take a dental dam to bring it back to demonstrate or get a free weight, etc. And make some choices and modify in order to be able to do what you want to do without it having to be hands-on. So obviously questionnaires, taking the history, medical history, observations are things that can be done, but a lot of other exercises can be modified as well. So think of alternatives to hands-on treatments, and alternatives can include using the caregiver, for example, in some contexts. But I'll add on a little point here that if you're using the caregiver, you have to consider what that means for the caregiver. Is this an increased burden, an increased caregiver burden? Is this an elderly caregiver who has medical problems themselves? So make sure to take that into account. You might want to combine, when possible, in-person and telerehabilitation interventions, when possible, and if applicable, based on your assessment of the situation. You should also consider cultural considerations and regional considerations. And what does this mean? You are now going into the person's home. They are at home and their region. What's available around them? What do they have access to or not have access to? And what would they accept or not accept within their home? So you need to take that into account. And lastly, but very importantly, you always need to ensure safety, which Hélène mentioned. And this is, as with every physiotherapy intervention, but it's particularly relevant in telerehabilitation. And throughout all this, really what stands out is you need to use your clinical judgment. If you feel you are missing components in your evaluation to be able to make an adequate diagnosis or an adequate treatment plan, this needs to be noted. And lastly, I have a few kind of ethical considerations to take into account that were addressed a little bit at the beginning also by Sarah. So you need to note an informed consent from the patient. It should be noted in the file that this is being done by telerehabilitation. We did recommend, prior to this context, tended to recommend to try and have the first assessment in person when possible. But clearly this is not always possible. So that you need to note whether you've been able to gather all the information you needed or not. Perhaps consider using some of your colleagues in the rehabilitation teams to gather information that you cannot get in person. You should have at your fingertips the emergency phone numbers available in case you need to contact them, and know who you would contact in case of an emergency, someone nearby or a caregiver. Make sure to still keep your physiotherapy file complete with all the progress notes as you would normally in your settings. Use your clinical judgment throughout. I can't say that enough. And with regards to reimbursements, I'd say the policies are changing very, very quickly. So watch for new developments. But the point about providing quality care, quality physiotherapy care in telerehabilitation is very important. And we don't want to undervalue that or present it as an alternative that's not as good. In most cases, when well prepared, it is. I have here a few links to some documents that are available, which have some very good resources and guiding principles in physio. The first one prepared by the Order of Physiotherapists in Quebec, and the second one in Alberta are good documents, but there are actually many more out there, and some of them being produced very quickly. So I invite you to check the websites regularly from your professional order in your province. So in conclusion, for what Dr. Carivo and myself wanted to really transmit to you, always ensure safety, use your clinical judgment, but even if you can't do it all by telerehabilitation, think about what you can do right now. There are quite a few components of our intervention in physiotherapy that we can do without the hands-on component. And that includes everything related to even advice and teaching, exercises, etc. And take the time to think about how you're going to do this. Don't rush into it. And consider whether at some point, maybe once you are able to or someone else can do it if you will need to see the person in person at some point. Thank you. We have here our emails if you want to contact us, if you have any questions, and the website for the research team that Hélène mentioned at the beginning, and the Facebook group.
Thank you, Dalia and Elaine. I really love that bird sitting on the wire, and then the Wi-Fi one, the bird sitting on nothing. That was pretty hilarious. Okay, so I get to reiterate some of what was previously highlighted in stroke and Parkinson's disease populations in what we know about MS from the MS literature. So there's a wide range of telerehab interventions that have been researched for people living with MS, and they vary a lot in terms of what the actual intervention is, but also how they were delivered. So was it in person? Was it synchronous in person, asynchronous? Was it a web-based platform, video conferencing? But overall, they show the benefits. So in MS, especially our clients who are they have more impairment in their mobility, it is a huge energy and time saver to do these assessments and interventions in client convenient settings. This minimizes not only the distance barrier, which in Saskatchewan is huge for us, especially if you want to access any sort of specialized care, but also the time, the cost to the client, but also healthcare system overload. For another benefit that we have found is it allows us to see how our client moves and functions in the context or in the environment that we hope for them to be using these skills in. So we can actually design more individualized, tailored programs that are likely to succeed in their environment. So we can get creative and use stuff in the room that they have, or help identify strategies to overcoming certain barriers in their house. The research does show that it has comparable efficacy to in-person physiotherapy, and this is based on both patient-reported outcomes, so in MS, fatigue, symptom severity, impact, and quality of life, but also on some physical outcomes, which are primarily what we're targeting in MS. The most common patient complaint is gait and balance. Okay. So I mentioned the methods vary. In the literature, there's video conferencing. So this is the main form. And it is also from the literature, the most recommended form for delivering rehabilitation, but combining it with things such as phone calls, text messages, and emails. So I think it is important to realize that those are also considered telerehabilitation. And rather than just our video conferencing in person, you're gonna have to consider packaging other ways of ongoing monitoring and support. So these phone calls, text messages, and emails, the research has suggested seem to be most useful for encouragement and reminders and monitoring. So it's something you would implement in terms of their intervention, you would implement after your initial assessment. Other platforms exist, such as apps or web-based platforms. Most of these tend to have an asynchronous monitoring and feedback. So maybe the client logs on, they do their program, and then as the physio, I can log in later and check their diary or check their discussion board. But it's not necessarily that face-to-face option. And some of these platforms are building in that face-to-face feature. Okay, so like all rehab in MS, the literature is a little bit behind our stroke literature, but thankfully evolving. So the first systematic review wasn't until 2015, and that was actually a Cochrane review. There's a small number of studies included, so only 9 RCTs, and they were all published prior to 2014, and it's not surprising that it commented on the lack of small study or the lack of larger studies. So these are mostly smaller studies, but it does show the promise for telerehabilitation, and it also showed that proof of concept, that efficacy. So in the 5 years after that, there's been a rapid increase in research. So a more recent systematic review showed the largest effect side in improving motor, so our balance and mobility of telerehab. It's also effective in addressing cognitive concerns, as well as improving what this review referred to as participation level outcomes. So some of the symptoms that limit participation: fatigue, depression, and quality of life. So that 2019 review only included studies till 2018. And I have to say, it is a rapidly growing evidence base. So even from the early 2010s, there are other pilot and feasibility studies that were not included in these reviews, and they have contributed to that database of proof of concept and provided strong rationale for larger studies. But I have to say now, there are a lot of larger ongoing studies. For example, one in the States is currently enrolling 820 people. So we're really going to get some great data, and forced into this use of telerehabilitation with the COVID environment, it's only going to get better. Okay, so some insight from some of the studies we've run in Saskatchewan. I've been a part of a research group where we looked at a web-based platform. Unfortunately, this platform is not publicly available. It's only used in research at this point in time, but it's called Giraffe Health. It was designed by Lorna Paul out of Glasgow, Scotland. And our specific study looked at individuals with moderate to severe disability from their MS. This platform does provide that asynchronous feedback. So the physiotherapist could design the program for the patient. You could also set up their diary. So there were some incorporated behavior change strategies. And we compared it to what usual care was, and it showed to be as effective in the objective in our quantitative analysis. However, we did randomize based on whether or not our participants were community ambulators. So the number of patients we had that were in a wheelchair was small, but they appeared to be more responsive to the web-based intervention than to the control, which I think is what we would expect when you think of all the barriers that telerehabilitation helps us overcome. Another study that we're currently running is using individualized approaches to telerehab. So we do have the option for in-person assessment, but we're offering individualized physical activity coaching, and how the clients access their physio is completely individualized. So it could be telehealth, it could be video conferencing, which I guess is the same as telehealth, but also emails, text messages, or in person. And we're finding this is really helping to support that chronic disease management component. But overall, these web-based platforms, or this blend of telehealth, they seem to offer the best benefit for people who want more flexibility or who have large distances to travel. Okay, so overall, what we can learn from the literature on telerehabilitation in MS is that you can use it with confidence. So I encourage you guys to go forward and use it, but of course, to continue to evaluate how it works for you in your practice and what else is needed. And I also encourage you to share that information back with us. So be a part of Jennifer's study that I showed at the beginning of this talk. This is how we're really going to move forward with implementation. The other thing is, the research shows us it is as or more effective as in person. I put in brackets there, more effective, because it really depends on what study you're looking at or what the outcome was. So for example, there's some good literature showing that telerehabilitation is potentially more effective for fatigue management in individuals with MS. There is lots to be learned still, that can be said for most of our rehab profession, but the area is rapidly developing. There are larger studies ongoing, and what I'm excited about is the innovation that's happening in conjunction with telerehabilitation. So wearable technology to allow more remote testing and monitoring, and to pair that with video conferencing. That's really going to help us with our implementation and help us overcome some of those limitations that exist in not being able to do an in-person assessment. So these are my tips for implementing. I encourage you guys to try as much as possible to pre-collect any proxy or emergency information. So what I mean by proxy is, is there a caregiver? Is there a neighbor? If this person really needs another individual in the room for safety, then try to arrange that. But let's say, worst case scenario, you're in a session with someone and they do have a fall or something else happens. You need to know the emergency procedure for that client. I want to emphasize what Dahlia had already highlighted, to be cautious of caregiver burden and overload, and consider resources to support them as well. So I loved that very first video that Elaine showed, the caregiver exercising as well, and she was right into it. Okay, so get an idea about what technology your clients already have and how you can incorporate that. So not just, okay, are we going to use a tablet? Are we going to use a laptop? But do they have a step counter? Do they have any other form of wearable technology that they're already using or that they could use that might supplement your assessment as well as your monitoring and progression? I encourage you to create templates. I made this mistake where I started just replying to everybody individually, one-on-one, and then you realize you're answering the same questions or going over the same detail. So generic email templates are really helpful. I did a few videos on how to actually access the platforms, so you can just send those out. Give them practice links. If I had a session on Wednesday, my clients wanted to make sure on Monday, my clients with MS especially wanted to make sure on Sunday if they could access the link. Depending on the setting you're in, inpatient or outpatient, consider having admin support to pre-check that your clients can access this technology so that when you're with them and that time you're charging for can actually focus on your PT intervention. I also like to give examples of how they should prepare for the session. So make sure you're in a room that has the right amount of privacy for you and your household. Make sure you have enough bandwidth, as Elaine mentioned. But also, if you are concerned about balance, clear the room of clutter, make sure there's a sturdy chair around. I also like to consider what assessments do I need from them. So I have individual discussions. Is there an option to do a bigger home visit, like using a mobile technology or setting the phone back so they can do their gait assessment for me? And then you need to really think about what you're going to do. Let's say you have an initial assessment or someone is progressing and you've been using telerehab. You need to decide what you're going to do if you feel there's no way to continue without an in-person assessment. These are some MS-specific resources here. Again, they're client resources, but they're nice online platforms that might help individuals with MS feel more connected, one, in this time of COVID in an immunocompromised population, but also two, just that general idea of being connected. Thank you, everyone. If you have any insight to share from implementing it with your neurological population or in your clinic, please provide that back to us and we can get it out to the NSD community. There's also the opportunity to run more webinars or even informal webinars or discussion groups where our members who are implementing telerehab want to troubleshoot or share their lessons learned. All right, thank you so much. Keep well, everyone.
Thank you.
Thank you.